Carlos has talked a lot about the conceptual stuff and also what happens at global level. I'm going to talk a bit about what came out in the South African research, sort of why Carlos and I think I'm fine. Should I use the mic?
No.
No, okay. Why Carlos and I both found this issue of accountability so very interesting in the work that we were doing. We did this at the School of Public Health in the University of the Western Cape. It was me and my colleagues, who I've listed there and are here. We looked at 3 provinces of South Africa, mainly because South Africa is so big and so diverse that it would have taken us a lot longer to do every province and a lot more money. We looked at KwaZulu-Natal, Western Cape, and Eastern Cape for those South Africans in the audience. And I'm just going to be talking a bit about the issues that came out and some of the questions that arose that I hope will be useful for you in the discussion as well. So just to give you a bit of background, you'll notice that in the title I focused on NGOs, antiretroviral therapy, and accountability. The reason for that is quite simple. Antiretroviral therapy in South Africa is where the majority of the global initiative money has gone to. So that's why we focus on it. And since the government in South Africa started providing ART from the end of 2003, it's faced 3 reoccurring problems. The first is, quite simply, money. The second is human resources, who actually provides the services. And the third is patient access, who can actually get to the services consistently. And when we looked at the GHI funding, we found that most of it was PEPFAR related, and it went towards NGOs, a particular kind of NGOs. Now, it's come up in several sessions. People have said, you have to define what kind of NGOs you're talking about because there's such diversity. Well, we're talking about service delivery NGOs. And that's really where the split is in South Africa. Service delivery NGOs were ones who went to the public services mostly. There are some standalone clinics, and provided the resources that the government was struggling to provide in order to give ART services. They're not the same as advocacy NGOs. Service delivery NGOs are about service delivery. Advocacy ones are about political spaces and democratic discourse at a community level. So just keep that in mind as we go through this, that we are talking about service delivery NGOs. This is a conversation that can be expanded much more to talk about advocacy, but for now we're talking about service delivery. And what we found was that primarily the NGOs were formally accountable to limited constituents. An interesting question was just who are the NGOs' constituents? And did they have clients or constituents, which is a question we'll come back to again. Just to give you an idea of how ART funding works, you can see that there are 2 main funders in South Africa, the Global Fund and PEPFAR, the US President's Emergency Plan for AIDS Relief. Most of the money goes to service delivery NGOs from PEPFAR. For Global Fund, some of it does go to service delivery NGOs, but through the country recipient, which in this case is the South African government. Different levels. In South Africa, unlike other places in the world, we have had 2 of our provinces receive funding as well. Usually it's only the countries themselves. So in South Africa, it's the South African National Department of Health, the Western Cape, and KwaZulu-Natal. And then all of this goes to support community-level ART services. So we looked at this and we said, well, what does this actually mean in terms of NGOs? And we found that there were really kind of 3 different kinds of NGOs that were providing ART services. All of them were HR focused. So they were all about either training clinicians or community healthcare workers, or actually providing the clinicians the data capture as the community healthcare workers. And 3 issues came out again and again. The first is, was the NGO reliant on the external resources? The second was, did they involve the community, and how did they involve the community? And of course, well, we'll get to that, but who is the community? And the third was, where is their management centered? Now this all probably seems quite practical to you, but it actually had quite a fundamental effect on how well the NGO operated and who it communicated with. So the first type we'll call a large NGO working locally, usually an international or a national NGO, who often existed before HIV funding came along, so before about 2002 to 2004. And they shifted their services mostly to HIV-centered work. Many of them, interestingly, didn't go through the government structure when they offered their services to the places who are actually providing the facilities. Some of them did, but many of them directly approached the facilities to offer their services. All of them external funding. PEPFAR related was mostly, PEPFAR was the biggest funder. And when we looked at how they operated, they were providing clinical staff, or CH Robins actually, to provide ART services, and their management was not locally based. Their management was at provincial or national level. That's quite important, because when you have a question, who do you go to? How do you contact them? Who's the person who gives you feedback on what's happening? The second kind we'll just call a large NGO acting small. Similar kind of history, more likely to have worked with the government structures, funding the same. And interestingly enough, their operations were based at the local level, so near the district offices, which was quite an important thing, because it meant that when you had a problem, you knew who to go to, at least at the level at which they were facilitating their interaction. So in this case, it was usually district level. And the third kind was a local NGO, which there were not very many in the service delivery category. Basically, you're talking about ones that were community developed and managed. Interestingly enough, their funding was usually not from PEPFAR, and that was, frankly, because of the limitations attached to PEPFAR funding. We talk about accountability, we talk about donor accountability in terms of financial responsibilities, but there are also other issues tied to those financial responsibilities, the performance indicators, that these NGOs felt were actually restrictive on them being able to do what the community wanted them to do. And in terms of their operations, they were mostly volunteer, and their management was based in community level. Basically, with these three, what you had was a big difference between those who were spending money on a community and those who were actually working with the community. Accountability constituents, it's not actually required of an NGO by any formal mechanism. It may be required by an internal mechanism, but it's not required by any state regulation or indeed global regulation, though there are the codes of conduct. That's important because people can't automatically hold an NGO to account, particularly when they're reliant on the NGO to provide a needed service. It may not be a service that's provided in the way they want, but it's the only one they've got. So they can't actually do anything about it. And of course, accountability to stakeholders for the NGOs is required, which is a problem because that, as I said, that can impact on their ability to be accountable to the actual community. So to conclude quickly on this section, so we're going to go into the group discussion. NGOs, we found, should clarify if they work for a community or with a community. And they should think a lot about who are their constituents. And it'd be interesting for the NGOs in this audience to think about who are their constituents. And indeed, for the government people as well, to think about who are their constituents. When we talk about the community, who are we talking about? Are you talking about a geographic area? Are you talking about the patients you serve at the facility? Are you talking about, for example, district level government? Is that your community who you're serving and who you're expecting feedback from? Are you using local government as a proxy for communities? And are you using community healthcare workers as a proxy for communities? So ultimately, the question we have to ask is, do NGOs determine the community's needs? Or do a community's needs determine an NGO's work? And again, who do we mean by our communities?